So my first question is, we are treating acute myeloid leukemia with 7 and 3 in 1977. We are still doing the same in 2018. What is the best way to change it going forward by 2028 at least?
It is a very important and very good question because it truly reveals the area of our failure, and there is no denying that in spite of lot of effort that we have really not changed. Your own husband, Harvey Preisler, deserves a lot of credit in introducing better and different treatments for AML, and to some extent he was successful. Yes, 7 and 3 deserved some gratitude to Harvey Preisler, but Harvey also brought in high dose cytosine arabinoside into the formula, both at early, at initial diagnosis, as well as at relapse. But to come to the question, it is embarrassing, frustrating, and anger producing for all of us who have been involved in improving the treatment beyond 7 and 3. Why is it that we have not improved upon it? Lately, there have been a couple of drugs which have been touted as important progress. In my opinion, yes, they might be progress, but they are not important and they certainly are not new. We tend to exaggerate newer advances. The new drugs have been in the testing phase for the longest years, maybe 13, 14 years, and only a year and a half ago did it get presented to the FDA and added to the armamentarium. But has it changed the overall outlook for AML people? Unfortunately, in my opinion, no. What can happen in the future? It is hard to tell because good minds have worked against this disease for the last 20, 30 years. And not because that is a good reason to expect dismal future ahead, but I think that sequencing data have not been very helpful in AML. But in my opinion, in the next 5 or 6 years, we will find an oncogene or a gene which has more direct connection to acute myeloid leukemia than anything that we have discovered so far. So I am not losing hope. I'm being realistic that it is highly likely that our technology of working, understanding the human genome will bear fruit in AML as well. So that is all I can tell you.
Thank you. That's a very thoughtful answer. My second question is, there are 3.5 million papers on cancer, 135,000 published in 2017 alone. There is a staggering disconnect between scientific insights and translation to improved therapy. What are we doing wrong?
This is also an extremely important observation, Ezra, because there are two parts to my answer. One is that the observation that there are millions of papers and nothing has come through with the objective improvement in the treatment of cancer. you have to understand that with the ease of publication today, there is so much more junk being published. So when you throw the number of millions, if you look at those papers carefully, who would have the time to do that? But only a small fraction of those papers truly are meaningful. And when you reduce those millions into a few thousand, then the comparison does not seem as dismal. But there is no question that there are lots of publications and very little to show for it in the eventual outcome. However, in my opinion, there is progress. Let us not exaggerate our failures, because if you look at the recent developments in areas about which you and I know we work on that. MDS, the disease that you treat, in my opinion, in the last 15-20 years, because of your own contributions and your colleagues around the world, their contributions, there is a much better approach to the disease. Previously, MDS people were relegated to wait and watch and transfuse as and when necessary. We do not use that approach anymore, and that is a progress. There are some targeted agents which people exaggerate and feel and claim greater successes than they actually are. But even if you don't keep the exaggeration in mind, realistically, people with MDS, a certain fraction of those patients who do benefit from the newer hypomethylating agents, but because the drugs are thrown across the board to a large number of people who should not be given this drug, therefore the percent remissions that we calculate becomes unduly small. Whereas if you relate it to the people who prospectively ought to benefit from the newer agents, there has been an enormous progress in this disease. I would say, without being an authority on that, but the percentage of people moving into AML is lower in people who have responded to hypomethylating agents. In the same vein, how can we forget the enormous response change in a paradigm of chronic myelocytic leukemia? We would be failing in our responsibility to point out that the discovery of agents directed at BCR-ABL has turned CML from a 100% fatal disease in 5 to 8 years to 90% today. Within the last 20 years, the changes have happened. Gleevec or imatinib has indeed kept those people alive with good quality life, whereas almost 20% of all the people who eligible for allogenic hematopoietic stem cell transplantation, they are going down percentage-wise as well as absolute number-wise, not for any other reason but that imatinib and its related newer agents have demonstrated that it is not necessary. These people keep on taking the pill and are living a normal quality of life going on to 15, 20 years. So I think that there is progress, except that we tend to emphasize the negatives. In chronic lymphocytic leukemia, the disease that I personally treat, I feel that although some of my colleagues, who are all very smart, very competent, we tend to exaggerate the results of newer treatments. Without that exaggeration, there is no question that there is a great degree of improvement both in survival time as well as quality of life of CLL patients who previously, as recently as 8 years ago, would have died with the miserable complications of disease such as infections, bleeding, etc. That is not happening. But what we are doing is to claim that we have cured CLL. Unfortunately, that is not true, but we certainly have given longer life to much more high-risk CLL patients than was possible as recently as 6 to 8 years ago. And things are improving. Newer drugs are coming up. And I think that without doing an exaggeration of data, we are making slow but very definite progress. That's all I can tell you.
Thank you. Third question. The fact that children respond to the same treatment better than adults seems to suggest that the biology of cancer is different, but also that the host is different. Since most cancer incidence increases with age, even having good therapy may not matter for older people because the host is decrepit. Solution?
Solution. I will be sort of fooling myself if I said to you that I might have a solution. Yes, all the observations that you have made in this question are true. But let's take these in pieces. Yes, childhood ALL is curable, cured, and fantastic results. But the same disease in the adult, particularly in the very elderly, is a fatal disease. The same treatments that we give to the younger population do not work, or it has been discovered that we are doing a very slow step progress, that instead of all adults from 18 to 100 or 18 to 90 years of age, if we took adolescent young adult population, AYA, there is progress by using the childhood ALL protocols. So what you have observed in the latter part of your question is indeed true. That is, the disease is different. Not only is the disease different, we all know that disease is extremely heterogeneous. And so far, with all the molecular biology testing, we have failed to demonstrate where the critical difference between childhood ALL and older adult ALL, what those differences are. But there is no question that that is going to be found out. And the last part of your observation is self-evident. That is, the elderly, real elderly people, those people unfortunately come with the baggage of aging. In an aged population, beside the cancer that we are talking about, they also have heart disease compromise, lungs, bones and joints, brain. Those comorbidities compromise the ability of the oncologist to attack the underlying ALL as effectively as one does in childhood ALL, where fortunately there are no comorbidities. So, is the biology different or the host factors are different? I think both of them are true, particularly the host factors. And I think that we are not addressing the elephant in the room, and that is our American attitude toward the fatality, the mortality of all of us. And by saying that a 70, 80-year-old person with the cancer, ALL, ought to look forward to a cure or short of a cure, a long-term remission. What we are truly doing is not addressing our society, looking our society in the eye and say, look, fellows, people, brothers and sisters, we are born, and one thing that is for certain is an eventual death. And death is not an enemy, death is not a failure, and your question's last part cries out for us as physicians to prepare ourselves and our society that when it is time, we should let go.
Thank you. That is a profound answer. Thank you, Kanti. Two short questions now. You have great knowledge and experience in the cancer field. If you were given limitless resources to cure cancer, what will you do?
Surely it is a great open-ended challenge. I will say that there are two things. One is I would emphasize to my colleagues and society at large the need, the crying need for us to study, learn, and understand the history of medicine, which we have been neglecting to a criminal level. And one thing that I learned from a great book by Mukherjee called Emperor of All Maladies, and then his subsequent book, Gene, that it is a shame that we as medical students, as doctors, health professionals, we do not teach ourselves how we have made to the point of today. We claim and are proud of progress, but how did we reach there? How did James Watson and his predecessors work to understand what is the structure of DNA? A discovery more than 50 years ago laid the foundation of what we today call the discovery or understanding of human genome. It did not fall from the skies. And Similarly, today the technology of CRISPR, a method of editing the entire genome, identifying those genes which are connected to a particular disease, whether it is sickle cell anemia, thalassemia, or Lynch syndrome. There are precise failures in our genetic makeup. Identifying those particular problems makes it possible for us to then correct them prospectively in utero. The entire field is getting opened, and as I just finished reading a very important book, Crack in the Creation by Dudna, I urge you all to read that book. That book is just opening the door of what lies ahead in the future. Future not in the immediate 5 years, but I'm talking about just as Watson and Crick's DNA structure took almost 40 years to yield practical benefits. Similarly, editing methods of Dudna and others in CRISPR technology will yield solution to human diseases, prevention of human diseases in the next 20 to 30 years.
Thank you. And the last question. It's more of a philosophical one. Offering patients with advanced stage non-curable cancer palliative but toxic treatment is a service or a disservice in the current therapeutic landscape?
I think I handled this question already, and that is those people who deserve palliation and not a curative treatment, facing the issue of death is important. It is not necessarily, as we consider, a failure on the doctor's part and failure on the patient's part. And I think there comes a time when that has to be accepted with dignity, courage, and forthrightness. Thank you.
Thank you very much, Kanti.
Okay.
Any last statement you'd like to make?
I'm grateful to you for giving me the opportunity of making these large statements. Thank you.
Thank you.